Good evening. I'm Hartford Healthcare's Tina Verona. Thank you so much for tuning into this Facebook Live edition. I am joined by Dr. Stefan Kachala. He's a thoracic surgeon here at the Hartford Healthcare Cancer Institute, an impressive first in the state of Connecticut. He is the first thoracic surgeon to perform an esophagectomy, so that's quite a feat. Tell us how you did it, and this is robotic assisted surgery. So talk us through that procedure.
Yes, to clarify, it's the first robotic assisted esophagectomy that we've done here in the state of Connecticut. With my partners and I, we're really seeking to embrace the robotic platform. So the conduct of the operation is very similar to that to a traditional esophagectomy. The patient, once they're placed on their backs on the operating room table, through the abdomen we dissect free the esophageal tumor, turning the stomach as well into a tube or conduit so it can replace the esophagus once that's been taken out. Once the abdominal portion of the procedure is finished, patients turn on their left side. Through the right chest, we take out 2/3 of the esophagus and connect that tubularized stomach to the remnant esophagus. The differences between the traditional open approach and the robotic approach is really simply the size of the incisions. And the benefits from that are a much more rapid recovery, less pain, and finally, with regards to the instrumentation available to the surgeon, there's that same level of precision that you have with an open procedure.
Now, we do want to stress again that this is robotic assisted surgery. Dr.
Correct.
Kachala is still performing the actual procedure,
yes,
but assisted robotically and minimally invasively. And there are a lot of advantages to the patient with robotic assisted surgery, especially with an esophagectomy.
Right. So even with regards to some of the more traditional minimally invasive approaches, I think the robotic assisted approach really provides additional benefits. There's less trauma to the tissues involved, especially from an open procedure. The incisions are far smaller. Although there's several of them for each of the robotic arms that we employ during the surgery, they're simply about 8 millimeters in size, which again, if you can imagine, you know, a incision that's probably somewhere around 6 to even 8 inches long versus several that are simpler or smaller, much easier to control the patient's pain, less trauma to their abdominal tissues, and then finally there's less bleeding because of the level of precision we can employ there with through these smaller incisions.
Yeah, now the first procedure that you did back on March 1st,
correct,
the patient is doing very well.
Yes.
And the recovery was almost instantaneously. He was doing well almost immediately after the surgery.
It was, you know, this was an older gentleman, and we were making plans that he would still be in the hospital the standard amount of time that we have for our open procedures. And he really surprised us that the following day, seated upright in a chair, asking us when he was going to leave the intensive care unit, quite comfortable and not really even, you know, in the additional day, maybe very little limited narcotic use. He actually seemed to think that Tylenol was sufficient for him. So that was a very exciting first for us to see that kind of first evidence of the benefit of robotics for this patient.
Yeah, and I was going to say, in a traditional, more conventional method to doing this type of procedure, you probably wouldn't see that so quickly.
Definitely, yeah, definitely with the open procedure. Sometimes patients are even kept asleep overnight after surgery. But now my partners and I have been performing the minimally invasive approaches, and just now we're really starting to bring to bear in order to, again, embrace that robotic assisted platform because of its benefits we feel are there for the patients. Really, same number of incisions as perhaps a laparoscopic approach, but the level of instrumentation and precision available to the patient to not have to make any compromises in that cancer surgery for them.
Yeah, and I want to talk about the precision because I think that that's really vital, because with this robotic assisted surgery and with the smaller port of entrances, you are really targeting the areas that you need to target.
Right. So again, with an open procedure, you're making a large abdominal incision. It's really the surgeon's hands and their assistants that are all in there trying to retract the tissues necessary, get down to the target tissues, dissect that free, and then the other aspects of the operation really involve staging the cancer, meaning taking out all the lymph node bases that drain that area. So when you're doing it minimally invasively, for example, doing it laparoscopically, you're essentially, for the most part, using long chopsticks to really access that area. And so you have to operate within the zone of mobility of your instruments, the degrees of freedom that you have. And what the robotic assisted approach affords you is really, if you think about it, another wrist that's available on that robotic arm. And that articulation gives you far more degrees of freedom in being able to dissect under tissues, around tissues, and the level of precision really being able, just like I was using my hands open, to dissect the lymph nodes free of the major blood vessels within the abdomen.
Now, robotic-assisted surgery versus the conventional method, once you're inside actually performing the surgery, it is still the same, right? You're still doing the same thing.
Right. I think this is something that I was really drilled into me when, during my training, was that it doesn't matter how you conduct the operation if you don't do the right operation for the patient. The bottom line is, regardless of the approach, whether it be minimally invasive or open, at 8 weeks, if you didn't do the right operation, it's not worth its hill of beans if you did it minimally invasively. So to really get that benefit for the patient, you have to accomplish the same ends that you would in an open procedure, but then grab those benefits of the more rapid recovery, less bleeding, and the same level of precision.
And less risk of infection, too, because you have a smaller opening, right?
Some of the studies haven't really borne that out this much. They definitely hope in our own data collection, as we're accruing patients now with these robotic-assisted surgeries, we're collecting data and tracking these outcomes to make sure that are our patients really getting those benefits? And we feel that they are in the short term, but time will tell, and we'll hopefully be able to publish that data at a later point.
And speaking of time, are you in the operating room the same amount of time versus conventional method, or is it a little bit quicker?
Given this was the first procedure, we were actually anticipating this would be a longer procedure for us, but actually it was the same or perhaps even slightly faster in this case.
Yeah, are you thinking as a surgeon, gosh, where was this? You know, where has this been?
It's time really flew with this procedure, and then again, the other side, it's really helping us say, well, what other procedures that have for so long been open, can we afford them now minimally invasive because of their level of complexity? Perhaps we didn't want to venture there minimally invasively, but definitely with a robot, we're able to really have that high level of precision that we expect from an open procedure, yet keep it minimally invasive.
And in terms of the patient population too, if you have an elderly patient that has esophageal cancer, who maybe is too old to have a conventional surgery, could this minimally invasive robotic-assisted surgery, could it be a potential operation for somebody older?
I think that's an area where as surgeons, we always want to say yes, but in the end, you don't want to compromise the patient's safety. And so in this case, this patient, while he was a little older and he had some comorbid conditions that would make him high risk for any esophagectomy, we made sure that he was safe for getting an open procedure as well. Obviously, given the fact the complication rates with open surgery are higher, keeping it minimally invasive had a much more rapid recovery for this patient in the end. So in the end, we want to make sure this patient's afforded, but we're never going to compromise patient safety in the end. Absolutely.
And of course, obviously with any surgery, there's always an extensive workup prior to having surgery to make sure that that is the best option. We do have some questions. Let's see. Nina asks, would your new robotic surgery for esophageal cancer only help those with stage 1 or 2? Thanks, Nina, for that question.
Actually, we consider all patients who are candidates for esophagectomy for the minimally invasive approach. That's the main caveat to determining whether or not you would benefit from surgery. Now, this patient recently was more advanced, so from my perspective, if you're a candidate for an esophagectomy, a robotic-assisted approach would be appropriate given if you're stage 1, stage 2, or even stage 3. Now, with stage 3, there are some additional therapies that may be given before surgery, such as radiation, which may increase the complexity of the dissection. For example, sometimes after radiation, the tumor can get stuck to structures around the heart. Clearly, in this time, sometimes it's better to simply have the surgeon's hand there to ensure we're not risking injury to major great vessels coming out of the heart or going into the lungs. So, whereas minimally invasive is always on the table, and especially robotic-assisted approaches, again, we don't want to compromise the patient's care. So if in the end it's becoming too difficult, and I simply know as a surgeon that if my hand's in there, I can really determine how do we complete this dissection, open may still be the best approach. But absolutely, robotic assisted for first stage 1 cancer, stage 2, and even stage 3.
And the results of stage 1, stage 2, stage 3, if it's caught early, the prognosis in patients?
So if it's caught early, we typically reserve that for patients who are in early stage cancer, such as stage 1 or 2. So the patient's prognosis is really related to their stage, and it's always trying to impress upon patients that despite the fact you have a stage 3 cancer, as long as you're a surgical candidate, that means that there's a chance of cure for those patients. Now, the second, I guess, corollary to that statement is when we say we're catching something early, we usually say stage 1 cancer, and obviously they have the best outcomes. But if you have a complication from stage 1 cancer, it doesn't matter. We need to get you out of the hospital. We need you to do well after surgery. And there are people who have devastating complications even after early stage therapy.
Let's talk about some of the symptoms of esophageal cancer for folks out there to be mindful of.
Yeah. You know, nowadays, one of the most common symptoms or diseases that people suffer from that can lead to esophageal cancer would be that of reflux disease. So your typical symptoms associated with reflux would be indigestion. Now, patients who have esophageal cancer, they're known to complain of severe burning pain, also associated with reflux. And I'm not trying to say, of course, that all patients who have reflux have esophageal cancer. It's a very, very small minority. However, if you do have a reflux disease, it's worth making sure that you're following up with your physicians, and perhaps a referral to a gastroenterologist or a surgeon may be applicable to you. Other symptoms associated with esophageal cancer, difficulty swallowing is a very common one. Patients with a persistent cough or changes in their voice such as hoarseness. And finally, the most worrisome usually for patients is unexplained weight loss without even trying.
Yeah, and so I think that the symptoms to be cognizant of with acid reflux, if you do, I think your point is good that if you do have acid reflux, just to be a little more mindful and have that open dialogue and the communication with your physician, I think is so important with that as well. What are the, what would you say are the causes of esophageal cancer?
There's two main causes that we always associate with esophageal cancer, and that's smoking and excessive alcohol consumption. Two lesser-known causes, one lesser-known cause, since we've already spoken about reflux disease being associated with esophageal cancer, is that a diet that's actually poor in fruits and vegetables and other antioxidants. It's a weak link, but there's a known associative effect there.
Yeah, and I know we were talking earlier about acid reflux that could potentially lead to esophageal cancer, but I do want to say that the numbers are small.
Yeah, they are very small, but they are there. And it's so, again, if you do have reflux and you suffer from chronic heartburn that you feel is poorly controlled, the first step is to reach out to your physician and see if is it appropriate for a referral to a gastroenterologist or a surgeon for further evaluation.
Sure. Now we are again talking with Dr. Stefan Kachala. He's a thoracic surgeon here at the Hartford Healthcare Cancer Institute. You have a class coming up on another topic, lung cancer. That's coming up on April 10th, I believe, in West Hartford. You can call the number on your screen to register for that class. Let's talk about, I know that you want to sort of dispel some of the myths around lung cancer and sort of demystify some of the content that's out there. Talk to us about, give us a little preview about what you'll be talking about. I know screenings and so forth, but what's that message you want to get out there?
So the main thing is, you know, in terms of demystifying lung cancer, it's to help patients understand what options are available to them. First of all, many people already know some of the major risk factors associated with lung cancer, especially smoking. So I don't think there's anything new that I'm going to describe there. However, it's a new thing that patients are not aware of is the fact that there are screening studies available for people who smoke in order to determine, do we have any nodules that are worthy of intervention, or do we have an early cancer? And the recent studies have shown that the CT screening can actually help detect early lung cancers, which in the end help patients achieve a rate of cure that much better.
Yeah, and is it true that if you stop smoking like immediately, the benefits already are there? Like if you've been a smoker but you stop and you know you're a week out, a month out, like the benefits are already there.
Yeah. What people always associate with smoking is that there's only a cancer risk, but there's actually far more effects. The immediate benefit of smoking is actually to your heart. The number of toxins that are in cigarette smoke put a great strain and actually have a vasoconstrictive effect. And as we know, if you're constricting blood vessels, that's less oxygen to your heart, less oxygen all over your body, especially your brain. So just stopping smoking, immediate benefit to high blood pressure and letting those blood vessels open. The other toxins that are there, such as that can be causing things like injury to blood vessels, also take some time to remit. Then there's the ongoing benefits to your lungs. So the actual immediate benefits to your lungs are realized over a period of several weeks. And that's really in terms of the vasospastic and asthmatic benefits, the production of excessive sputum or mucus. That takes some time because your lungs are actually healing that ongoing injury from the smoking. The effect that takes probably the longest time to go away and never goes back to zero is that cancer risk, because the toxins that are present, now our lungs are great filters, and they retain a lot of those toxins and chemicals, and they can affect genetic changes to the cells within our lungs. And those effects can be permanent. So the cancer risk will decline over time, but that's over a period of years of not smoking. You have the immediate benefits to the heart, you have the period of benefits over 2 weeks to the lungs, and finally those risks of cancer take some time.
All right, Nina has follow-up questions. Do you see, on the topic of lung cancer, do you see much lung cancer caused by radon? We have high levels in our area.
So, in terms of direct causative effects, I haven't had too many patients actually tell me that their house has high levels of radon. Clearly, Nina, yes, you are absolutely correct. There's a direct causative known effect of radon in terms of how it harbors within our lungs and increasing our risk of lung cancer. But to answer directly your question, no, I haven't had that causative effect, but we do see a fair number of lung cancer patients who have never smoked a day in their life. And sometimes it's difficult to ascertain what was the cause in those patients who have never smoked cigarettes. Unfortunately, although there are associative studies with radon, I still haven't had a patient who's directly come to me telling me we did our best to treat the radon in our basement, but maybe that was a benefit effect. So not yet, but definitely there is an association between the two.
And thanks for that question, because you always hear environmental factors. You hear a lot about that with breast cancer.
Yes.
You see rates where you see women diagnosed with breast cancer who have no family history, but they live where chemicals are sprayed on the lawn, or you hear a lot of environmental factors. So
actually, an environmental factor, that's an excellent point. Thank you for bringing that up. Asbestos is actually mostly associated with a very, very rare condition known as mesothelioma, which is a devastating disease. However, what patients don't understand is that asbestos is far more commonly associated with lung cancer. And in fact, patients who smoke and have had an exposure to asbestos actually have a 50 times greater risk of lung cancer than they do of mesothelioma. So again, if you have a known association with asbestos exposure and you're smoking, please seek out your physicians and ask, am I a candidate? And most likely you will be a candidate for some screening procedure.
And in terms of lung cancer, we've come a long way because these screening options are available.
Exactly,
these CT scans, which we didn't have before. So, and lung cancer, it's almost like once the symptoms develop, it's almost too late at that point. So with the screenings, that is so important to stress.
It's very silent. It is very silent. And again, most patients will tell me, I would say the bulk of my patients, when they come to us with a screening study that has a new biopsy-proven cancer, they say, I feel great. I don't feel anything. I said, that's why it's great we did this study. Or
they're surprised to learn they have a diagnosis because there are the symptoms are silent, as you said. Melissa asks, what is stage 3 pneumonia?
So typically, Melissa, when we talk about cancer, we talk in stages where early stage cancer is usually limited to the organ and in a small area, such as stage 1 or stage 2. Stage 3, either the tumor has grown very large and is touching other organs, or there's involvement of lymph nodes as well. Typically, when we talk about pneumonia, it's a benign process. Stage really isn't associated. However, a lot of times lung cancer can masquerade as pneumonia. So you may have heard that association there of a stage 3 pneumonia, or a patient being told they have pneumonia that never went away, and next thing they know they have cancer, when in reality the pneumonia was a secondary effect because the cancer is actually obstructing something, causing that infection there. But typically we don't describe pneumonia in stages, mainly cancer.
Okay, thanks, Maria, for that question. Susan wants to know if an endoscopy would decide whether or not a gallbladder needs to be removed.
So again, this is a little outside my area of expertise. Gallbladder surgery, usually the need for gallbladder surgery is usually performed by a general surgeon, or also a gastroenterologist would be involved in making that decision. So in a nutshell, probably not, but that is to say that there are several studies that are employed in evaluating the gallbladder. Again, seek out your primary care provider, your gastroenterologist, or a general surgeon helping making this diagnosis. Usually an ultrasound is employed, sometimes a CAT scan. Endoscopy isn't the primary mode of diagnosis. However, it could be used if, for example, you have a gallstone that's blocking a duct. But again, that's not the primary modality, but in fact a complication of gallstone disease. And again, if you've had that procedure where a gallstone needed to be removed endoscopically, yes, usually those gallbladders do need to come out.
But your primary care physician, always a good place to
start for that.
Absolutely. Yeah. Carol asks, can benign bronchial cysts grow back after surgery?
Yes, there is a chance of that happening. Usually associated with, so again, benign bronchial cysts are sometimes congenital, meaning you've had them from the time of birth. And they're a small growth made up of cells from the bronchi that can develop fluid, and they develop adjacent to your trachea and other airways. So if there's a large fluid collection that perhaps was incompletely excised, sometimes due to their proximity to important structures, some surgeons may feel that it's too difficult to really completely peel them off. That sac may reaccumulate. If, however, the appropriate surgery has been performed, it's very unlikely for them to come back. Usually we see these cysts coming back when they've just been aspirated. That means they've taken a needle and to take out all that fluid, and sometimes people actually inject various sclerosing agents to prevent that area from coming back and instead just to heal it and scar it down. But yes, there's a possibility. However, if the entire sac has been resected, it's unlikely for it to do so unless there was a tract that was still present at the end of surgery. And it's difficult sometimes to track those down, to find them and to that. But usually, to answer your question directly, hopefully not.
Can those benign bronchial cysts, could they develop into cancer?
So there are some types of cysts that have been known to eventually become malignant. They're very rare. Again, if you have that pathophysiology of having a bronchial cyst, please see your pulmonologist, see your thoracic surgeon, and for the full workup and explanation about what your particular diagnosis is, which typically sometimes can only be made after they've been fully excised. But yes, there is a low rate of transformation. That's one of the reasons why we perform the surgery. Other indications would be for infection or compression and symptoms.
So, and that's with any cyst. I mean, if you completely excise that cyst, if you completely remove it, obviously the chances of
are very, very low of it coming back.
Regrowth or coming back are very low. Whereas if you're just, taking the fluid out, it's still there. Right. Absolutely. So that could lead to. So as far as your class, again, we're talking with Dr. Stefan Kachala. He's a thoracic surgeon at the Hartford Healthcare Cancer Institute. He has a class coming up in Blueback Square in West Hartford on April 10th, all about lung screening, cancer treatments, any new treatments by way of lung cancer on the horizon or that we're doing now. So
in terms of the minimally invasive procedures we have available, we're making use of really in terms of diagnosis, we have nowadays, it's been around for quite some time, there's the traditional methods of using image-guided biopsies where you would go to the interventional radiologist and the biopsy is performed through the skin. The main risks of that procedure are pneumothorax, which is very small typically. Some patients would, although do ask me, and I do offer, there's additional methods of diagnosis where we perform them bronchoscopically. And this is usually performed by an interventional pulmonologist or a thoracic surgeon, where we take the patient's CT scan and it's co-localized in a machine to actually navigate through the patient's airways to that lesion, and we can obtain biopsies that way. Finally, we make use of, there's a new type of endoscope. It's been around for quite some time, almost a decade now, and it's really rising in its acceptance in terms of trying to eliminate a surgical procedure called a mediastinoscopy in order to biopsy lymph nodes within the center of the chest. The great part of this is there's no incisions, it's a small needle. Main complaints a patient would have after this procedure is a sore throat. Go home the same day. And usually we can get you some answers that day too, as long as sufficient tissue's been obtained. That's pretty remarkable. With these advanced screening techniques and procedures that we have in place, have you noticed, or is there data suggesting that the lung cancer diagnoses have gone down because we've had these tools and techniques now to better screen and screen earlier? Actually, we find that we're detecting more, and the study that I spoke of earlier that finally said that lung cancer screening is something we should be doing for our patients. It was published in the New England Journal of Medicine, and it found that we're detecting earlier cancers, which of course if we can detect earlier cancers means we have higher rates of cure. So what we're actually finding is now that we're looking for more cancers, we're actually finding more.
Right. But those, there's a good probability that they're caught early enough, whereas before, without those screenings, those patients would just continue to go along.
Absolutely,
and then come to you when the symptoms are just, when the cancer is developed.
Right. And the main goal of having this really armamentarium of all these different ways of diagnosing these lesions and having our our colleagues in radiology really assist us in making these diagnoses is really to be able to make sure a patient doesn't get to the operating room with either an incorrect diagnosis or have an unnecessary procedure. So if we can determine that this is a benign lesion, we're going to want to make sure that patient doesn't end up getting surgery. So really to remove this. So that's really the goal of having all these new techniques, to definitively diagnose and make sure the only patients who get the real cancer operation are those patients who have cancer.
Are the ones that need it. And I think also, too, that it's important to point out the multidisciplinary approach.
Absolutely.
The fact that you're a thoracic surgeon, you work closely with the radiologist, so it's like you're all working together for that one patient so that they're getting that best care.
That's actually a great point. Thank you for bringing that up. So within the central region, at the Cancer Institute of the Hospital of Central Connecticut, which is located, I know it's confusing for a lot of patients, actually directly on the border between New Britain and Plainville. So it has two addresses, but bear with us. It's an amazing, beautiful building, lots of great parking, easy access to physicians, and great access for our patients. So we've started a new lung cancer tumor board there where we meet on a weekly basis. Once patients, typically that morning, have seen an oncologist and myself, and we've obtained diagnosis, gotten them their PET scans, and we have an excellent nurse navigator, Noah Mencher, who works closely with the patients and us to really get these patients to this clinic. Now, what's the main goal of this clinic? It's really to decrease that amount of time from diagnosis to treatment and really shorten it. So we help with the assistance. Again, our kind of lead on this has been Noah Mencher, and she's fantastic in terms of coordinating all these studies, getting these doctor's appointments, whereas before perhaps you saw your primary care doctor, then your pulmonologist, then the medical oncologist, then the surgeon over a span of maybe months. We're really shortening things down to 2 weeks. So really increasing that access, decreasing the amount of time, and getting patients answers and a plan already so they know what's the next step for them.
The patient navigators are so crucial.
They really are.
I mean, they're worth their weight in gold, because you would be booking these appointments, going around and trying to facilitate everything yourself. But having that navigator, having that person on your side is so critical.
And it's been great coming into the Hartford healthcare system and being introduced to all these great nurse navigators who really are there for the patients all the time. And again, we have at Mid-State Medical Center, we have another excellent group, and we meet as a multidisciplinary group twice a month. And there's also, on a weekly basis, a large multidisciplinary group meets here at Hartford Hospital as well. So again, we're really trying to embrace this team approach, that every patient gets an opinion from every specialty as often as necessary.
Right, and Mid-State, by the way, is in Meriden. You perform the esophagectomies here at Hartford Hospital.
Correct.
You're at Hospital of Central Connecticut in New Britain. So wherever you may be.
And we're trying to expand offices and offerings to other Hartford healthcare facilities.
Dr. Kachala, this has been great. Thank you so much for sharing your expertise.
It's been a real pleasure. Thank you.
And all of the wonderful work that you're doing. And congratulations on that first esophagectomy in the state that you performed back on March 1st. Well, we hope that you took something away out of tonight's live Facebook discussion. And don't forget, Dr. Kachala will be in West Hartford and Blueback Square on April 10th coming up. You do need to register for that class. It's all about lung cancer. You can just call the number on your screen, 1-855-HHC here, to get registered for that class. Thanks once again for joining us. I'm Hartford Healthcare's Tina Verona. We'll see you soon.